So with that, we're gonna turn it over. As I said, we're running a bit behind. And so I would just remind our lightning talk presenters, if you can take 2 to 3 minutes to share. This part is basically kind of a continuation of Stephanie's presentation and the presentation from Kim and Jeremy, continuing to lay a sort of shared foundation of what are some of the things already happening in terms of the crisis care continuum, so that when we have our afternoon discussions, it can really be building on what is already there. So we have this order listed on the screen, and I will go ahead and call on folks in this order, but I am going to stop sharing the screen so that we can just focus on hearing from one another. So stopping sharing, and Christine, are you there and able to present first?
I am. Good afternoon, or still morning a little bit. But looking at the perspective from the education system and looking at it through what we call a multi-tiered system of support lens. And I know I'm supposed to speak to prevention, but I'm also going to mention the 2 other. But in the prevention category, in an MTSS framework, we actually call that universal support, and that's for all students. And when we look at all, think of it as, if you're looking at the medical field, your general classroom teacher is the same as a general practitioner. So your teacher is a GP. And when you go see your general practitioner for services and supports and needs that you have, they give you a lot of preventative things, right? And so they'll tell you, let's look at your weight, let's look at your diet, let's look at your eating habits, your sleeping habits, your drinking habits, those kind of things, and making little changes and knowledge that they have to make those adjustments so you can be healthy and successful. Well, a classroom teacher does those same things. The hope is that a classroom teacher has all the trainings and supports that they need along these things that we're talking about, especially when it comes to mental health, suicide prevention training, trauma-informed practices, culturally responsive teaching, those kind of things that help build their repertoire of resources and support so they can respond in the classroom to children that come in, regardless of eligibility for any other services, but what can we do for all students? And so that's kind of general practitioner wise when you look at it from a medical perspective. Now, we do know some students don't always respond to what we need in those preventative measures, right? So our reading programs that we're offering, our math programs that we're offering, they're not responding, I've tried all of my tricks as a teacher, what do I do? So that next step we go to is responsive, or what we call supplemental within an MTSS framework. And that's where you lean in on your specialists, right? And so I might refer to a counselor, I might refer to a special ed teacher, I might refer to a behavior specialist to help me as a classroom teacher work with this child who might not be responding. And so if we look at this from a medical perspective, I went to my GP, I have some stomach issues, I don't know what to do with that anymore. My doctor has tried everything, we don't know what to do. So he's going to refer me to a gastrointestinal doctor. I don't stop seeing my GP because I'm seeing this other specialist. I still see my GP to help me still mitigate everything else so I don't have further things I have to address down the line. I see my GI doctor, you know what, I do a scope and he finds that I'm going to use a personal situation. He finds that I have nothing wrong with my GI, but I actually have endometriosis. Wow, okay, I have a problem here. My GI doctor cannot treat me for endometriosis. He has to send me to a surgeon. So now I see a specialist, an intensive specialist. So that becomes stabilization. I'm going to stabilize now what's going on inside of me. So then I can get back to my normal functioning. At the same time, I'm still talking to my GI doctor because we know this is what's happening. And I'm still talking to my general practitioner because I still have to keep him in my court because he's who I need to see on a regular basis for my health. So within an MTSS framework, it works the same. I might have to lean on other people to help me with a specific child, while never stopping providing services and supports as a classroom teacher. So that's how it works within an MTSS framework. Back to you, Julia.
Thank you. All right, and next I will turn it to Sonia. Are you here with us right now, Sonia? Okay, it looks like Sonia might not be with us currently, so we'll move to Mandy Taylor.
Hi, thank you. I will try and keep it brief and work from my notes. So the California LGBTQ Health and Human Services Network is a network of over 60 LGBT serving health and human services organizations in California. That is frequently LGBT centers. And LGBT centers vary widely on what services they provide, how large they are, and that's based often on population density and geography, whether or not they're rural. One statistic I want to make sure I share during this time is that when we did a survey of over 3,000 LGBTQ Californians, 78% of our 18 to 24-year-old respondents said that they had considered suicide in their lifetime. So our young people are in crisis, and this was before the pandemic hit, and we know those numbers are even higher now, as young people are oftentimes literally going into the closet in order to access services in secret so that they don't experience harm in their home for being out. Our LGBT centers are often community funded. Historically, we were excluded from mental health systems, and so a lot of the centers across California were built by community members supporting community members, and use a lot of private donations, individual donations. Most LGBT centers in California don't even have paid staff. Some of you might be more familiar with larger centers like San Francisco, LA, Sacramento, that have paid staff, but there are many across California, like the NorCal Outreach Project up in Shasta County, or the Tri-County Alliance in Amador, that don't have any paid staff. They are run entirely by volunteers. And when they do have access to funds for crisis prevention or intervention, it tends to be through grants and not through Medi-Cal billing, because they don't have the infrastructure to do things like Medi-Cal billing or staff or electronic medical record systems. Services tend to be peer-centered. It is a generations-old tradition in the queer community that we support each other. It's almost exclusively peer-based in LGBT centers frequently. You'll see groups meeting every day, often for young people, for 20-somethings, for elders, for trans folks, for people who are just coming out, and that is crucial in preventing crisis. Many like the Source in Tulare also offer immediate access to care. You can get 6 weeks of counseling at the Source while they help you navigate accessing mental health services. You can get a counselor right there on site who will help you learn how to navigate the system and the insurance, and is that person really affirming? Because for most places, all you have to do is check the box saying you're affirming. You don't actually have to prove it. And so there's a lot of fear about reaching out to non-community providers or providers that haven't been vouched for, because maybe they just checked that box, but they don't actually have that competency. And then the other thing that we're seeing as a primary crisis intervention and prevention is meeting the basic needs of the community. So there are a lot of LGBT centers who do things like access to housing for transitional age youth that are experiencing homelessness. They might offer a food bank with food that is donated by other community members. Things like that that are getting people's basic needs met. And the reason those LGBT centers are often providing those services is because our community is afraid to go to non-LGBT spaces to access those resources. They're concerned, can I go to the Salvation Army food bank? Or are they gonna mispronoun me? Are they gonna say something about the fact that I'm here with my partner and it just doesn't feel safe? Or am I gonna be able to access this housing? Am I gonna be able to be housed with the correct gender? And so often we're seeing, as a crisis prevention, just helping people get their basic needs met so that their mental health doesn't escalate to crisis. And also just want to identify not being able to access these primary sources of care and being assured that they're affirming in itself causes mental health distress. So thank you so much for offering the opportunity to share that information.
Thank you, Mandy. Yeah, it's great to be hearing these different examples of ways that people are finding and receiving and providing services across the continuum already. Sonia, I see that you've raised your hand. Welcome. I didn't see you previously, but please go ahead and unmute, and we'd love to hear from you about the community-defined evidence practices.
And Julia, thank you so much. I actually am having like some very serious tech issues. And so I can't get the camera to work, and I'm in a place where the internet is spotty. And so please forgive me for that. That's why I keep falling on and falling off. So
no problem. We know what it feels like.
Yeah, so I appreciate this opportunity. And I don't know how much time you've given me, but I'm going to try to just be brief. And anyone who is interested in learning more about the practices that I share, of course, you can always reach out to me, or you can even go to the California Black Women's Health Project website. If you type it in Google, you'll find us. And then there are other practices that I also want to share. And if you're interested in those, there's the California Reducing Disparities Project that has 35, I certainly call them CDEP, community defined practices, crisis interventions that are standing in the gap and holding spaces for a variety of communities. Mandy was just talking about the LGBTQ community, and there are 7 projects in the CRDP that cover the LGBTQ plus community as well. So for California Black Women's Health Project, there are 3 that I'll just share with you very quickly. And one is the one that's funded by the CRDP, and that's our Sisters Mentally Mobilized advocate training program. And what we do is we train community advocates. We train Black women to be advocates and activists in their families and in their circles of influence. And we train them to navigate systems. We train them also to help to support their families and the people around them to navigate systems. And in terms of the crisis, like crisis care in particular, what we do is we use a sister circle model of engagement for pretty much all of our work. And that is an evidence model to support mental wellness. But we utilize that model deeply, deeply infused with culture, heritage, and supportive circle practices, and creating an opportunity for the Black women in our spaces and places. And that's in the 5 counties of California that have the largest population of Black women and girls. And you can find out more about that if you go to our website. But that work has really been very instrumental in helping us to really to sort of stay the course, or to provide coping skills, to provide training around recognizing signs and symptoms of anxiety, depression, and other advanced conditions, and then to be able to intervene and to provide opportunities, for our community members to have some place to go when. And I don't think there's anyone on here who isn't aware that, for our community, it's incredibly challenging for us to find, quality, dedicated, culturally, rich and affirming mental health services. And that's in the public and the private spaces. The other program I want to share with you is Sisters Aging with Grace and Elegance, our SAVE program. And that program is centered on Black women along the aging journey, 40s and up until 90s. And it really is designed to address isolation. And the program was incredibly strong during COVID, particularly when we had to, step in and really, against our own, kind of general safety to, do door knocks and wellness checks, on our seniors, and then spend a great deal of time doing a lot of technical training to, give them an opportunity to be able to get access to virtual spaces, because we began facilitating a number of circles. I mean, I can't even tell you how many at this point, where we can create a virtual community for our older and aging Black women to come together, to talk, to deal, heal, to share, many of whom were suffering from some severe impacts of isolation, especially during COVID. And then the third program I just wanted to very quickly share is our Anti-Violence Ventures program. This is very new and unusual for the California Black Women's Health Project, because the project Anti-Violence Ventures is centered around democratizing the violence prevention movement. But at the center is the voices and the lives and experiences of Black men and boys. And we have developed and designed that project with support from the Blue Shield of California Foundation. It's an innovation which really, again, is focused on bringing Black men into conversations about community violence, which they generally are invited to, but domestic and family violence as well, which they tend to be left out, unless you're having conversations about toxic masculinity. But we center their experiences and the trauma and the things that are happening in their lives that could either lead to, a further crisis or lead to a violent experience, or the historical violence and issues that they've had in their own lives, and how that continues to play a role in who they are. And the last thing I want to tell you is that LA County, and some of you, I don't know who's on, particularly from the public, but the LA County Office of Violence Prevention is working very diligently, and I'm on the Violence Prevention Council here in the county. Is working very intentionally on crisis intervention that's centered around investing in trusted community resources to be active and available, in the event, when trauma impacts our community. And this is a community at large, so that when trauma impacts a community, so that you have trusted messengers who are readily available and have been trained to be directly responsive. And it's very similar, like what I believe they're investing in. And I mean, it's a growing intervention. Is very similar to, if you're in Sacramento, there's the Safe Black Space. I'm not sure how many of you might be familiar with that, but that was a crisis intervention that was born out of law enforcement murder of a young man in Sacramento, and the community needed a place where you could come out and you could connect. And we say talk, deal, and heal, but we also mean cuss, scream, cry, and do all of the things that come with that. But in an attempt to again create a gap filler, to create a mechanism for people to be able to have a space to cope, because we're now in this post-COVID stress disorder, if you want to call it post. We know that our community continues to be reeling from the loss, and that's every area of loss. And suicide rates are fast growing among young black boys, and that is something that is so unusual for our community. I grew up, and we always said, and I don't want to be dismissive of anyone, but we always said, hey, Black people don't commit suicide. Like, we don't commit suicide, I mean, we're just constantly running from our pain. But to see these numbers rising is so disturbing. It's so disturbing. And at Black Women's Health Project, I mean, we're working with our partners and our colleagues in the state, just to try to really think about what we can do to address that. So I just wanted to say, if anybody has anything they want to ask me about, please reach me in the chat, find me online, or whatever, Black Women's Health Project.
Thank you. Thank you, Sonia. So that takes us into our crisis response speakers. Just a reminder, we are trying to get through 7 more speakers. So please keep it to 2 minutes for each of you, if at all possible. We're gonna go first to Lenore. I am actually not seeing Lenore here, but in case you've joined on someone else's account and that's why I'm not seeing your name, here's your opportunity to speak up. And if not, I will go to LaShawn. And again, just friendly reminder to please keep it to 2 minutes. Thank you.
Thanks, Julia. Hi, everyone. LaShawn Francis, Children Now. And I want to talk a little bit about the Family Urgent Response System, which, despite its name, is not just for crisis. So we would fit squarely in the prevention category as well. But FURS is a program that was enacted in 2019, and its goal is to support foster families, so children and caregivers within the foster care system. And it would provide, or it provides, 2 things. The first is a 24/7 warm hotline, statewide run hotline, and the second is a county mobile response system. And the idea here was simply to help kids stay in homes. So what we noticed at Children Now was that a lot of those foster care placements, we were having issues with stability, and stability is a really big part of making sure emotional wellness is taking place when children are removed from the home. And a big part of the stability issues were issues that could be worked out if the parent or caregiver had an opportunity to talk to someone. It could be an issue as small as my child won't go to school today and is having a tantrum. In the past, they would call 911 for such issues. And as you can all imagine, those things would escalate. So now we have knowledgeable folks managing a warm hotline on the statewide level. And we have a county mobile response system that has trained professionals who can come out to your home if necessary. Right now, it has been deployed as of 2021 into all 58 counties. And I think I already mentioned that it was 24/7. I invite our partners, BHTF and CSAC, to add anything if I've missed it, but I think I've got the basics there for a 2-minute rundown.
Perfect, thank you. And yes, definitely understand that 2 minutes is such a tiny amount of time to explain all these programs that you guys have and are working so hard on. So just to note again that this is really laying the foundation for the conversations that we're going to be having after lunch in the separate Zoom meeting. So looking forward to everyone participating in those, and thank you for sharing. Next up, we have Leandra talking about 988 call center training for crisis services.
Hi, everybody. I'll try my best to stay in my 2 minutes. Leandra, CEO of CBHA. Glad to see you here representing mental health and substance use disorder providers across the state. And historically, we've had about 5 member agencies that have run the National Suicide Prevention Lifeline Centers. And these include calls, text, and chat systems. These are across the state, throughout the state. And as of July 2022, as we all know, these centers will now be designated 988 call centers. So we believe that call centers play an important role in the crisis ecosystem, and in this continuum, they're often the first place that someone will reach out to via a call, a text, or a chat option. And pretty incredibly, they're very effective, with over 90% of these first contacts being resolved at this crisis center level. So that's something that we should focus on and praise and be really proud of in our state. You know, CBHA has been working closely with some allied organizations led by the Steinberg Institute and the Kennedy Forum to really advise on legislation to create as infrastructure for the 988 call system that's to go into place. As you may remember last year, when it appeared that the AB 988 bill was not going to survive or move forward, we really pivoted quickly alongside our call center members. So we advocated for one-time funding to really get the call centers prepped for July, which is right around the corner. And so the administration was so gracious. And so there was a $20 million allocation to help call centers really get prepped. And so they've been working with those funds to set up a lot of different systems. We simultaneously pursued some private funds, and Molina Cares was also very gracious and provided a health equity grant. And so we're working with one of our call centers, WellSpace, to purchase and design a platform where trainings can be shared across all of the call centers. One thing we saw is that of all the 13 call centers, they were all kind of doing their own thing in terms of trainings and how they worked with their volunteers and staff. And so we aimed to standardize a lot of that, lift up best practices, and create a way for call centers to be connected, especially as we approach 988 and the influx and calls and texts and chat that they're bound to get. And we also really, we believe that integrated care is important. So we also saw the translation of that over to the whole 988 call system. And so we, in understanding that intersection, we've hosted some forums with call centers to kind of join with their other colleagues in this space. So Office of Emergency Services, SAMHSA, 911, et cetera. We've all kind of come together to work on what we're going to do to move forward together. So that's my quick and dirty. I hope I made the time limit, but that's an overview of what we're doing with the call centers and the training platform. Thanks for the time.
Great, thank you, Leandra. And next up, we have Ken. Thank you all for moving so quickly through this. We have Ken, and then we'll have the Crisis Stabilization and Services presentations.
Great. So I want to talk about the most intensive end of the service continuum, but I want to talk about it in context because it's one of the most important parts and one of the least important parts. And Christine referred earlier to the MTSS pyramid. And I think she did it perfectly when she talked about how you don't give up your primary care physician when you go into more acute crisis. And that's how I want to contextualize the highest end of this pyramid. It is almost useless if it doesn't have these other components. Someone asked me why we were trying to implement so much so fast all at the same time in terms of the Children and Youth Behavioral Health Initiative. And the answer to that is because we have to. Because each of the components are dependent on the other to work. If you don't have crisis prevention, your crisis response system simply becomes overwhelmed and then is also less useful because you don't have the ability to follow up and serve. If you don't have crisis stabilization services, you have no discharge mechanism from your highest end services. They become useless because they're not available. So I really want to emphasize that as the most important thing. So the centerpiece of the high-end crisis service is a very intensive wraparound. And I don't mean case management wraparound in the way that we've referred to it in some places. I mean wraparound that can deploy the most intensive services to wherever the youth and family are and for whatever their needs are. So we can deploy a broad array of mental health services, including therapeutic behavioral services, including one-to-one supports. And it can do that wherever the youth is through the system. So once that system is in place and can hold, then you have the ability, when your crisis prevention services need a higher level of service, to move to mobile response. And mobile response, of course, can respond where the youth are and then refer to this intensive wrap service that can deploy services to stabilize. But you can't stabilize in every single situation. And so from there, typically we would recommend that you move to a 23-hour crisis services type of unit where you have a more secure setting, completely one-to-one, highly supportive, that can help to stabilize and then deploy those services to whatever environment the youth originated from, wherever the family needs. Let's say you can't stabilize there within 23 hours. Then a very small number of highly intensive residential beds are necessary. We've done it in the form of a PUF, a psychiatric health facility. We've done it in the form of a highly supported SDRTP. We've done it in the form of family-based services with intensive one-on-one services. And again, those resources are in the case of Ventura County, we have only 2 of those beds for Ventura County because we have a very good system of additional supportive services. In other counties, of course, you would need more, but they don't need to be in a single place. They do need to be linked to the CSU. And then you have a series of step-down services that can include highly intensive family-based services that are staffed, intensive services, foster care, intensive supported families, and again, all supported by wraparound. I feel like I've just had to explain the Torah while standing on one foot, but that gives you the shortest summary. And I hope we'll have time to talk more about how this fits with the broader continuum. Thanks.
Thank you very much for trying to explain the Torah while standing on one foot. And I'm seeing a number of comments in the chat thanking you for sharing. So thank you. And next up we're moving on to the crisis stabilization and ongoing services portion. We'll turn to Michelle first. And just again, note, we are getting real short on time, so please keep it as quick as you can, knowing that we will circle back for in-depth discussion after lunch.
Thank you, Julia. Michelle Cabrera with the County Behavioral Health Directors Association. And I am going to be describing a bit about our crisis receiving and stabilization services in California. Generally speaking, when we talk about this category of services, we're talking about facilities that provide up to 23 hours of crisis stabilization of some kind. So we're talking about things like crisis stabilization units, which is a specific licensure category, maybe think about an urgent care facility or sobering center that specializes in working with mental health or substance use disorders, but it also includes categories of services like peer respite or crisis residential services. I think it's important to call out that these services may also be specialized around certain subpopulations like adolescents or youth, for example. And the sustainability and the sort of array of services that are available often is tied back to some of those licensure or other requirements that come along with these service types or facility types. So although many of our counties really want to lift up additional crisis stabilization units, for example, the model that is required for staffing and reimbursement has been really challenging. The state made a pretty significant investment in our CSU capacity under SB 82 grants that were administered through CHAFA about a decade or more ago. And, you know, that's helped to build out our statewide capacity, but sustainability has been a real challenge, particularly with some of the staffing requirements that are involved in running a CSU. And the fact that reimbursement under Medicaid stops at that 23-hour mark. And that's because of something that we often talk about, which is the Institutes for Mental Disease, or IMD exclusion. Any care over that 23-hour mark is not reimbursed under Medicaid. And commercial insurers oftentimes do not reimburse for these services either. And so there's a real challenge there with trying to recoup reimbursement under private insurance plans. In fact, counties have reported that when they try to seek reimbursement from private insurance plans and then bill individuals who have private insurance, that grievances from people with private insurance about being billed for those crisis services are oftentimes among their top county behavioral health grievances. So real challenges there, real holes in terms of ongoing long-term sustainability. These services are also really challenging to sustain in rural or sparsely populated communities. I will say that any kind of residential services also have been especially challenging during the pandemic. The core mission of a crisis stabilization unit, I also want to call out, is not, sort of to take pressure off of law enforcement or hospitals as an end in itself. We must remember that under federal and state law, hospitals are absolutely an essential part of our crisis continuum, and we will always have a need for hospital emergency departments, whether it's to provide a medical screen, so certain psychiatric conditions are actually medical conditions that appear like a psychotic episode, or when there's self-harm and a person needs medical attention for detox, those sorts of things. So we definitely need to do more to make sure that our hospital emergency departments are more welcoming and hospitable, and that we continue to reduce stigma across our medical model providers. As we are thinking about our crisis stabilization and receiving units too, I would be remiss if I didn't mention the need to make sure that we are building out and thinking about throughput, to Ken's earlier comments. I know that's not the focus here today, but part of the reason why we have those overstays beyond 23 hours in our CSUs is when we don't have a provider who's willing to provide either that higher level of care or the step down that's necessary to make sure that that person can be safe and in moving along their journey on the continuum. And I want to point out one more thing. Cal Mesa, who was on here earlier talking about CalHope, funded an analysis of our inpatient bed needs throughout California. One of the things that they found is that, again, we need to look up and down the continuum when we're looking at need. An open bed may not mean a bed that's available to you for that individual. And so we really need to look at not just numbers of beds, but the willingness of our providers to say yes to taking someone who has a medical comorbidity, a justice involvement history, or who may have other additional needs or challenges. And so,
Michelle, I'm so sorry to interrupt, but we do need to get to our other presenters and make sure that we get on to lunch. But I really appreciate you kind of bringing in that whole point about the continuum, which is the purpose of why we're having this discussion today, is making those connections between the pieces along the continuum. So next up, we have Kim Lewis, and then finally we'll hear from Kirsten Barlow. So
Hi, thanks everyone. Kim Lewis from the National Health Law Program. I can't stand on one foot and recite the Torah like Ken, so I'm gonna really have to try to hard here. So, but I wanted to highlight 3 points really about crisis response services for children, youth, and Medicaid or Medi-Cal in California based on a paper we recently published called Children's Behavioral Health Mobile Response and Stabilization Services, known as MRSS. So first, as people have heard me say many times, the EPSDT entitlement in Medicaid for children and youth up to 21 is very broad, and that medically necessary crisis services, including mobile crisis services, must be provided to children and youth on Medicaid when medically necessary to correct or ameliorate a mental health condition or behavioral health condition. So CMS and SAMHSA have jointly said in 2013 guidance and recognized that mobile crisis response and stabilization services are instrumental in diffusing and de-escalating difficult mental health situations and prevent unnecessary out-of-home placements. And such services are coverable by Medicaid. The second point is that California needs to invest in evidence-based or evidence emerging practices statewide for children and youth and families when it comes to mobile crisis response. And while some of these practices exist in pockets in California, the approach shouldn't be left to providers or to counties specifically to develop on their own. So MRSS is a child and youth family specific crisis intervention model that meets caregiver needs based on a parent and caregiver defined urgent need, establishes like a first connection with a state crisis continuum. And unlike traditional crisis screening or referral systems, MRSS entails like a rapid development of a team specialized child and adolescently trained staff that provides intervention and builds on natural supports. It's important because MRS is really delivered and applied through principles that are core to system of care values, and that model is really critical for families and youth. It's a strength-based, youth-centered, family-driven, community-based, culturally, linguistically mindful program, and care planning is individualized, collaborative, flexible, based on children and family needs. So my third point is really that California is a recipient of one of the CMS planning grants to support preparing for the American Rescue Plan Act's qualifying community-based mobile crisis service intervention and is planning to do that service in California, where they'll get enhanced match for 3 years. Well, MRSS really fits well into that model as an enhanced funding that we need to take advantage of and build a statewide approach utilizing it to implement this system of care and values, and also meet the EPSDT obligations to provide medically necessary services for kids and youth in California. There are a number of states who are utilizing this as a statewide approach, and I think it's really important to start to identify those statewide practices and implement them, and not just in pockets. So I'll put our paper in the chat.
Thank you. Great. And then our final presenter is Kirsten Barlow. And before we move on, I just want to mention, in case folks are starting to need to leave the meeting, please make sure that you do jot down the link for our afternoon portion, as it will be separate from this one. Just another reminder about that so no one misses it. Thank you, Kim, and we'll turn it over to Kirsten for our final lightning talk, and then we'll take some public comment.
Hi, everyone. I'm Kirsten Barlow. I'm Vice President of Policy at the California Hospital Association, and I'm responsible for our behavioral health policy issues. I think we'll have lots and lots of chances for me to share with you not only the stories of what we're hearing in the field, whether that's in our emergency departments or in our inpatient psychiatric hospitals. So I don't want to go into too much depth about specific models, but really just to share a couple of observations that I think are key to our conversation here. I think that some of what I'm noticing is that most of the folks, when you bring a community of partners together, each of them feel in some way put upon by the increasing numbers of people with drug and alcohol and mental health issues that are coming to them that they feel ill prepared to deal with. Whether that's, the counties feeling like the mental health department's being asked to solve homelessness, or whether it's the emergency rooms that feel that their nurses weren't trained to really handle some of the behaviors that come in. Our first responders often feel, and paramedics, that they don't have the adequate support and training that they need. So I find it that it strikes me that in some of the communities that have been really successful in looking at that full continuum, the leaders in those different sectors really decide that they will own their part of the solution. And rather than sort of blame one another for, the burden that is being placed on them, they instead really start to acknowledge that they all play a key part of an individual's experience, and what can each of those parties do. I think, though, that one of the things I'd really like us to think through in terms of crisis is the ways in which our mental health and behavioral health generally landscape has really changed. That a lot of our civil liberties statutes are really intermixed now with the healthcare encounter that patients are having. So, when we wrote into law the civil liberties protections that we have for people of all ages to ensure people were not held against their will longer than absolutely necessary, we didn't have a system of healthcare that we do today, where we now have commercial and managed care plans through Medi-Cal have obligations for mental health and drug and alcohol services, case management, transportation. So when folks are presenting, to an emergency room or an inpatient facility, it gets to be confusing in terms of really where should some of the obligation lie to build capacity, and really should it still be solely the county mental health department's job to build out a crisis continuum, when in reality we know that mental illness and addiction do not decide to only affect people with low incomes. And so I think we need to really think about detangling sort of the patient's experience, both through the LPS Act lens, but also that's all a health encounter that person is experiencing with mental health and medical professionals. And we see, just like we've talked about with folks being stuck in a crisis stabilization unit for too long because we don't have adequate care. I think it's really throughout the entire continuum that we need more, and we may need to create some new sorts of places for people to be cared for that we don't have today, such as the crisis stabilization unit that can keep people longer than 23 hours. We see in our hospital psychiatric programs that we have many people who are staying beyond the point at which they medically need that level of restrictive care in an inpatient hospital, only because the next level in the community is not available. So I think we see all of these kind of roadblocks and bottlenecks that are really symptoms of the fact that throughout a patient experience from crisis and back into the community, we've really neglected to invest in some of what we need, and would really encourage us to think about those things, that we look beyond just simply the county public safety net and trying to build those out and look at our other healthcare partners. Thank you.
Thank you. Thank you to all of our lightning talk speakers. Really appreciate you making the effort to share quickly about these important services and points along the continuum, and also many of you making those connections between the different points on the continuum and the importance of it being a continuum, in fact.